The next speaker is Dr. Ashish Sinha, and he will speak on how do you investigate the patient sequentially for an etiology. Though some part has been covered by Moinak, but I think there will be some sequential step-by-step evaluation to determine the etiology. I will request Dr. Sinha to present his. Dr. Sinha is here. Dr. Sinha, please unmute yourself.
And I'm starting the video, and let me share the slide.
Okay.
Oh, it's taking time, so let me do it first. Yeah, that's good. That's good enough. Yeah, if you can do that. Yes. So, very good afternoon. Really, thank you all for accepting me to talk on something very, very important topic, which is dyspnea. And we have already been briefed about the how to tackle the case of and what are the causes of dyspnea. Now, I would like to present to you, and I would like to be very, very clinical on how to investigate the patient for an etiology. So, what is the cause of dyspnea? So, that is my topic, and I'm very happy, and I welcome you all as participants and panelists. And if you can be patient with me for a few minutes, and I'm definitely going to help you, and definitely we're going to be more informed about how to diagnose the patient just by asking the questions. So my next slide will be about investigation. I'll go to the next slide, and if somebody can do the next slide, I can. If somebody was shared, yes. So when we talk about the etiology of dyspnea, so what are the things which comes to our mind? What are the causes of dyspnea? It could be a cardiac cause, it could be pulmonary cause, it could be both cardiac and the pulmonary cause, and it could be a non-cardiac and non-pulmonary cause. So cardiac causes of etiology, we should always think about whenever we see a patient, what are the cardiac causes? There are various causes, very, very important, like CCF, coronary artery disease, cardiomyopathy, valvular dysfunction, pericarditis, and everything is over there. Now, what about the pulmonary causes? The COPD, asthma, restrictive lung disease, pneumothorax. These all can cause dyspnea in the patient. There could be a combination of both cardiac and pulmonary causes, and that could be a patient who has a COPD with pulmonary hypertension and a patient who has a chronic pulmonary emboli. Again, we have to keep in mind any case of dyspnea. These are the things we should look for, and that could be a non-cardiac and a non-pulmonary causes like metabolic conditions like acidosis, pain in the anterior chest wall. So this another neurovascular disorders. So I'll go to the next slide. So basically, we should remember that these are the basic causes which we should look for, the generic categories. Next slide, please. Yeah, this is one, the onset and the courses. Now, whenever we get a patient, we always ask whether it's an acute or is it chronic. Now, the subacute cause is another one where we ask whether this dyspnea has happened within hours or within days or within weeks. Now, if it has happened within hours, we should think of certain situations like asthma, left heart failure, and pneumonia. Now, if it has happened within days, we should always keep in mind about pneumonia, ARDS, and left heart failure. But it has been going for certain weeks. We should always think about pleural effusion. We should think about anemia, muscle weakness, and some tumors. So next slide. So again, a host of causes, host of diseases, which we can always, if you just ask the question, you will get an answer. So without investigating, we have come to the diagnosis. So the investigation will be definitely taken care of by another speaker. But then just by asking, like onset and courses, like when we ask about chronic pulmonary causes, when we think about chronic pulmonary causes, what are the things which can cause dyspnea, considering the chronic pulmonary etiology? The airway disease like COPD, asthma, bronchitis, emphysema, and cystic fibrosis. What about the pleural causes of dyspnea? Effusion, malignancies, and fibrosis. And what are the parenchymal causes of, again, dyspnea? It could be IRDs. What about the vascular causes of dyspnea? Again, it could be vasculitis or AV malformation. Again, so many types, so many differential diagnoses we have just by asking a couple of questions and spending time. Next slide, please. So the next slide will be about the position. There are two positions which is very, very common in this situation. A patient who is orthopnic and the reverse of orthopnea. A patient who is orthopnic, like when they get breathless when they lie down. So what are we thinking of? A patient who complains of breathlessness when they are lying down. We should think of CCF, we should think of LVF, we should think of COPD, bronchial asthma, massive pleural effusion, ascites, and GERD syndromes. And what about the patient, next slide, what about the patient who are breathless when they are sitting position, the opposite of the dyspnea, the sitting position, the tachypnea, especially people who have large left atrial myxoma, patient who have paralysis of intercostal muscle, patient who have a massive pulmonary embolism. So these kind of patients will be breathless on sitting position and they get better when they are on lying position. the opposite of the orthopnea. Next slide, please. Okay. Now again, we can always ask these questions whether this is an acute, and we have talked about it. Now I want to be very specific into acute causes happening within minutes. The patient is sitting in a restaurant and the patient is having breathlessness. So what are we going to think about it? Within minutes, like respiratory causes will be acute exacerbation of the asthma. Patient was having a history of asthma and now he has developed asthma, maybe because of their condition where he's sitting. That causes a precipitation of asthma. Again, pneumothorax, it is again sudden and onset. Pulmonary embolism, again very sudden onset. Foreign body which has gone and he has choked and that causes dyspnea. What about laryngeal edema? Maybe he's allergic to prawns and he's getting breathlessness and dyspnea. So again, there are a host of things we should keep in mind. Dyspnea is a magic word, but the causes are innumerable. Another, what are the cardiac causes of dyspnea? One is an acute myocardial infarction, congestive heart failure, pericardial tamponade, acute valvular insufficiency, aortic dissection, and complete heart block. Again, a host of cardiac causes where the patient will get breathless within minutes. Next slide, please. Okay, this is a scale I want to skip. We all know about the NYHA scale and the dyspnea. So I'll skip this slide, please. I'll go to the next. Yes. Yes. Okay. Now we should always ask when we are asking for the etiology, when we're talking about dyspnea, when we're giving lots of leading questions to the patient. What about the precipitating factors and what the relieving factors? We should always ask to come to a conclusion whether exercise will precipitate the dyspnea, whether exposure to cigarettes or allergen does that. What about occupational exposure, working in a cement factory or in any kind of factory is precipitating dyspnea? And what about the obesity, whether the patient is having weight loss, all those things, medications, special medications, which is causing breathlessness, like painkiller can cause breathlessness, very commonly seen in our patients. Now, what are the relieving factors? Again, this is very important. What helps you? Like rest. Does rest gives relief to your dyspnea? Whether in medication, special medications give relief to your dyspnea. So again, this is very, very important. Spending time asking meticulously on the cause. Next slide, please. Okay, the timing. This timing is again very important. Another very important questions which has to be asked to everybody is whether your dyspnea occurs at night, whether it is happening mainly at night when you lie down, or it's always in the daytime. So when patient lie down, especially congestive cardiac failure, again very important. So this is very, very important thing. Patient will himself herself will give a history. COPD patients, they get more breathless at night. Bronchial asthma patients, sleep apnea, these all have nocturnal onset dyspnea. Now, again, we have to understand there could be underlying heart failure. So we should ask for people who complain of dyspnea after having heavy meals, like, conditions. I take heavy meal and I get breathless. It could be aspiration. It could be a GERD syndrome. So again, most of etiology just by asking questions, spending more time on questions. Next slide, please. I think we have done a lot. This is again very important slide because it talks about the algorithm of the evaluation of the patient. Again, history is the most important thing. History, and that gives you almost 90% of the diagnosis by the history. So investigation is definitely needed, but then unless and until you have taken a very good history, investigation no use. So when you take a history, you should always look for presentation, whether the patient, when he comes to you, whether he's breathless on walking to a chamber, whether he can speak in full sentences or not, whether his affective muscles are prominent or not, or what is the color of the patient, eye, nose, or what, whether the patient is having breathlessness while coming and talking to you. When you examine the patient, whether he is the pulse paradoxus or not. Again, these are all, whether the patient, when you do SpO2, what is the saturation, whether it's low or normal. When you examine the patient, you find wheezing, do you find real strong cries, and all those things that when you examine. So everything, JVP, when you look at the patient, JVP, whether it's elevated or not, gallop rhythm, murmur, all those things, look for the leg, diesel edema, cyanosis, as I said. So when you take a history and when you look to the patient, you have almost all the diagnosis. And suppose you don't have a diagnosis, then definitely I would investigate, which I'm not going to touch right now because another person is going to talk about it, investigation. So I'll skip this slide. Again, this investigation, I believe this has to be taken by, so I don't want to talk on this. So I think I should stop here because I was supposed to talk only on the etiology and how we, with a very good history, we can come to the etiology. Investigation, I'm going to skip. So I just go to the next slide, please. Again, this is the investigation which I'm going to skip. Next slide, please. Again, I'm going to skip this one. So my topic was limited to. So again, this I am going to stop here. What I'm going to look for when a patient comes to me is when we look for the clubbing, we look for the cyanosis, we look for the extremity when it's cold or normal, whether they have any polyps, whether they have a deviated nasal septum, whether they have a discharge from the nose. All those signs, neck pain, jugular vein distension, any edema, all those things we look for. And we should always think about, like on the right side of the slide, bronchocarcinoma, pulmonary fibrosis, bronchiectasis, lung abscess, pleural empyema. All these causes, when you see clubbing, you look for congenital heart disease, infective endocarditis. So all sorts of diagnosis can be done even before the investigation. So etiology and looking at the patient's clinical examination is the most important thing in evaluating a patient with dyspnea. Next, please. In general inspection, as I said, you have to look for anxiety, which can cause this. And there are a lot of functional causes of dyspnea where there is nothing. You look for, you find nothing, and that is the functional cause of dyspnea. Where any inability, the patient cannot speak. Now, again, whether the patient can speak or not in phrases and sentences, that also helps you into getting how bad the dyspnea is. You can always categorize the dyspnea. And as I said, the cyanosis, pallor, mental status. When you have hypoxia, your mental status might be deteriorated. So again, looking in before investigation is going to help us. Vital signs are very, very important. We should look for the pulses paradoxes, bradycardia, respiratory rate, temperature, whether fever can cause dyspnea. Again, blood pressure is very high, that can cause dyspnea. Again, all those things are there. Clinically, we should look for. Next slide, please. I think we have covered a lot, and we have done good clinical examination, and investigation definitely is going to help us, but then this clinical examination for etiology is going to help us. Chest X-ray will help us whether the patient is in emphysema or not. When we look for the respiratory muscles, accessory muscles, we can understand whether the patient is having tracheal stenosis or not. There are things which bronchitis, pneumonia, CHF. All this can be diagnosed just by good looking at the patient and by asking questions. Next slide, please. I think I have completed before the time, and I think I've covered almost all the etiology which is possible in diagnosing the dyspnea. So, coming to the cause of dyspnea, and if we are very meticulous into taking good history taking, and if we are very meticulous into analyzing, clinically examining the patient, almost everything has been taken care of. And investigation is definitely going to help us into coming and pinpointing to our clinical diagnosis. Thank you so much, and I'll appreciate further feedback from the panelist and chairperson. Thank you, sir.
Thank you, Dr.
Now,
Sinha.
thank you, Dr. Ashish Sinha, for the engaging lecture.